Good morning, everyone. My name is Wesley, and I will be presenting an in-service to my fellow new graduate nurses and junior staff members regarding 12-hour induced fatigue within the acute care system and its implications on patient safety and the workplace. I will be discussing its origins, definition, implications, and possible solutions. Historically, the 12-hour system was introduced due to staff shortages during the 1990s. In this, the potential savings, impact on recruitment, and perceived improvement in the continuity of care were amongst some of the reasons of its implementation. From a nursing perspective, increased time off, improved communication due to the decreased handovers during a 24-hour period, ease of documentation, ease of planning of care, and improved patient rapport were some of its benefits. Fatigue can be defined as acute feeling of exhaustion and a lack of energy, which can progress into a chronic state where burnout can occur. Where burnout is defined as a syndrome of emotional exhaustion, depersonalization, and decreased sentiments of personal accomplishment. In a review, it was indicated that 92% of nurses reported feeling fatigued sometimes and 71% as very often during a 12-hour shift. Moderate to high levels of fatigue were experienced by nurses working 12-hour shifts, where accumulated fatigue within 12-hour versus 8-hour settings resulted in negative patient and workplace outcomes. Altered sleeping patterns due to shift rotations were also found to increase this sense of fatigue. There is inconclusive evidence within the literature in regards to the impact of 12-hour shifts on patient safety, where some have indicated its support but found a non-significant association with patient safety nor with workplace performance. However, there is strong evidence in its opposition. In this, it was found that shifts more than 8.5 hours were previously linked to significant adverse patient outcomes. Similarly, working 12-hour shifts with no sufficient rest had been repeatedly associated with negative patient outcomes, where a decline in safety and quality of care were evident through increased catheter-associated UTIs, decubitus ulcers, failure to rescues, and patient mortality. Furthermore, medication errors increased threefold when nurses worked 12.5 hours or more. In this, reaction times were decreased by 8% following a 12-hour shift and 17% on the third 12-hour shift. Lapses in attention also increased fivefold following 3 consecutive 12-hour shifts, as compared to baseline. As such, these declines in neurocognitive function can be attributed to the impairment of the prefrontal cortex, which is responsible for the higher-level cognitive processes of planning and self-regulating behavior, which are highly susceptible to the effects of sleep loss. A healthy workplace can be defined as an environment where a nurse is able to function effectively and safely in a physical, psychological, and professional sense. However, occupational hazards such as needle-stick injuries, development of musculoskeletal problems, and sleep deprivations are increased as a result of working 12 or more hours where there are no significant rest days. In this, 70 occasions of severe drowsiness during work and 7 near-miss accidents were reported over a 1-month period, and 92 instances of drowsy driving and 5 near-miss motor vehicle accidents within a 2-week period. Nurses working consecutive 12-hour shifts have been reported to only have slept, on average, 5 hours between shifts, which is under the recommended minimum of 6 hours. Moreover, nurses who work 12-hour shifts received less opportunity for education and professional development. However, a more pressing issue is the creation of a super nurse culture, where fatigue has been accepted as part of the job, and that you just had to deal with it. where this is accompanied by a growing sense of personal guilt of not being able to meet these ingrained standards, and subsequently not being viewed as part of a team. Consequently, poor coping strategies have been created where this unhealthy workplace culture has been further propagated, evident in statements such as, "Nurses joke about fatigue, but I almost feel like there's a competition about it. Like, who's the least fatigued and who can handle the most?" In such cultures, fatigue has been perceived as an apparent weakness, and that meaningful discussion regarding the topic has become taboo. However, experienced nurses have expressed that the younger generation of nurses have a divergent perspective, where concepts of self-care and work-life balance are at the forefront of discussion. Despite this, the subsequent fatigue that resulted from this system, in conjunction with the perceived higher work pressures, have become a major indicator for attrition within the next 5 years, especially for younger nurses. Due to the hazardous implications of 12-hour shift-induced fatigue, certain policies and guidelines have been constructed to mirror the recommendations from current literature. As such, nurses on 12-hour shifts will adjust their shifts over a 4-week or 6-week period, where they will work 152 hours and 228 hours respectively. In this, they will work 12-hour shifts plus one 8-hour shift in a 4-week period, or 19 12-hour shifts over a 6-week period. There will be no overtime following a 12-hour shift. In this, the day shift will have a max duration of 12.5 hours with a 30-minute unpaid and 2 20-minute paid breaks, where night shift will have the same maximum duration but will have a 30-minute unpaid break and a 1-hour or 2 30-minute paid break. However, reluctance to take breaks due to patient acuity, staffing mix barriers, and guilt have been implicated within the literature. They must also be provided with a minimum of 11.5-hour gap between shifts, where the maximum consecutive 12-hour shifts will be limited to 3, and up to 4 if requested by the employee. They are not to be rostered on single days off unless requested by the employee. Furthermore, no more than 50% of shifts will be night shift, unless agreed upon by both employer and employee. However, on a practical note, nurses are encouraged to create appropriate sleep hygiene practices and to have open discussion regarding rostering. Nurses can incorporate naps of 15 to 20 minutes, as this has been indicated to bolster increased alertness while reducing symptoms of sleep inertia and fatigue, especially within those partially sleep deprived. Strategic consumption of caffeine has also been implicated to combat the effects of fatigue. However, it is encouraged to not consume caffeine past 11 p.m. to prevent daytime sleep fragmentation. This is an imperative matter as greater fatigue, poorer recovery, and greater loss of productive working time have been observed within younger nurses. As new graduate leaders, we can rectify these problems through the creation of a culture of safety and collective responsibility, as indicated in the Nursing Standards of Practice. This can be achieved by utilizing the legal structures of the state award, by effectively participating in our scheduled breaks to prioritize self-care and recuperation. Nurses should be implored to detach themselves from the prevalent supernurse culture and to acknowledge one's fatigue and to subsequently seek help, such as through the utilization of the buddy system. Through this, a culture of safety is created, underpinned by principles of self-care, well-being, which consequently translate into improved quality and safety of patient care, and to essentially realign with the nursing standards of practice. As such, open dialogue regarding fatigue should be encouraged amongst nurses to better support one another, which can again be achieved through challenging this notion of a supernurse. Thus, while 12-hour shift-induced fatigue remain rampant, I do hope that this in-service has given you some insight on its implications and how to combat it.